Welcome to this week's webinar on plantar pain. I'm sorry for the delay in getting this to you, but we are having work done on our house and we're living downstairs, so there's nowhere to go to get away from various noises. You see the local dogs barking, my dog barking back, lots of fireworks going off for some reason, or construction work. I have to work around the worst of it, hence the delay. Even so, I'm afraid there will be various background noises you'll have to deal with. So my apologies. First, if you are feeling like a challenge, identify the pathologies shown in the pictures. The answers are on the penultimate page of this webinar. Also, can you identify the music in the introduction slide? I'll let this image run for a couple of minutes to give you a chance at the challenge. This week we will look at pain in the areas of the distal, heel, medial and up the foot, the midfoot. The bulk of this webinar will concern plantar fasciopathy, which is the commonest cause of pain in this area, with plantar fasciosis the commonest fasciopathy. But there are other pathologies that cause pain here, including some truly rare conditions such as intrinsic muscle tear, and these will be passed over. The conditions we look at in addition to plantar fasciopathy will be the Elise Frank injury, spring ligament and tibialis posterior tendon tears, and biomechanical dysfunction. The last of these will be covered more fully when we look at them in more detail in a webinar dedicated to foot problems in the future. Elise Frank injury is a fracture or a dislocation or a ligament tear or a combination of all three or two of the three at the tarsometatarsal joint. The number of joints involved and the severity of the pathology is determined by the magnitude and direction of the force. While the pain can be over a more extensive area than my original question, it may not be so and may simply affect the medial side. The diagram on the right looks at the common mechanism of injury, so it can appear as a simple ankle sprain. The other picture shows the bruising characteristic of this injury, and outside of direct trauma to the area is almost pathognomic of a Elise Frank injury. They are uncommon. They can be low energy twisting injuries, or they can be higher energy injuries from falls. Football, both kinds of football, the real kind and the American kind, are common cause of this, as is dancing. In fact, anything where you're doing a fair amount of jumping about on toes. These injuries require immediate investigation in case a fracture or dislocation has occurred, as these may require fairly urgent surgery. So even if you suspect a mild injury, refer it for confirmation, particularly if the bruising is extensive. As with all traumatic injuries to healthy tissue, there is either immediate severe pain if the damage is less than minor, or the onset of pain is delayed if most of the problem is inflammatory in nature. In the case of Elise Frank, you can expect immediate severe pain and an inability to function either at all or at the level necessary to continue the sport if the damage is minor. The injury is likely to be over the medial half of the foot, so the bruising is probably going to be in the same area. And with significant damage, there will be visible swelling on the dorsum of the foot and probably palpable swelling on the plantar aspect. Obviously, there will be tenderness under the foot, but also dorsally. Active and passive flexion and extension of the toes will be painful, as will passive inversion and eversion of the midfoot on the hind. Treatment for ligament tears is generally conservative, at least initially, providing recovery is speedy, with rehab in non-weight bearing progressing through partial weight and then to full weight bearing. Surgery may either be by internal fixation or fusion. The top left picture shows the extensive bruising seen in more severe injuries, and it's running pretty much all the way from the calcaneus down to the ball of the foot. The X-ray beneath it shows the dislocation of the first tarso-metatarsal joint and a fracture of the medial cuneiform. And the X-ray on the right is really quite interesting. The left image is non-weight bearing, and there is little, if any, separation between the medial and middle cuneiforms, while the right image shows what happens when weight is taken. The spring ligament and tibialis posterior are major stabilizers of the medial arch of the foot, and if either is incompetent, particularly if they are combined, it will lead to major dysfunction of the foot in standing and locomotion. If the spring ligament is incompetent for any reason, it can lead to overuse and or degeneration of the tibialis posterior tendon with tendinosis or rupture eventually. And conversely, a rupture of the tibialis posterior tendon will probably result in overstretching and rupture of the spring ligaments. All of these possibilities are, of course, increased with the increase in amounts of activity. Rupture of either can result from sudden high energy trauma to healthy tissues or more moderate energy forces to degenerative. Healthy tissue ruptures result in severe pain, bruising and swelling, plus loss of the medial arch when the pain has subsided and full weight bearing can be achieved. And while the collapse of the foot is similar with degenerative tears, the response to the tear is less as far as pain, swelling and bruising are concerned, depending on the severity of the degeneration. The greater the amount of degeneration, the less response. The more healthy the tissue is, the greater the response. Degeneration either can be caused by chronic over-flattening of the foot to compensate for an ipsilateral long leg, neurological trophic malnutrition from axoplasmic flow compromise, neurophysiological issues such as reflex inhibition or segmental facilitation causing weakness of the muscle, or hypomobility causing overuse, and a few others. In the acute injury, there is severe pain on attempted normal weight bearing, an antalgic gait, or even an inability to bear weight at all. Also found is tenderness along the medial arch, pain on passive eversion and dorsiflexion, and if the tibialis tendon is torn, an inability to invert the foot initially due to severe pain and later due to weakness. The picture in the top left of the page shows the right foot when able to weight bear, or in the case of spontaneous rupture, immediately. It is called the too many toes sign because there are too many toes. They are visible on the right due to the abducted forefoot. The hind foot is invalgus. With spontaneous rupture, where there may be no pain or only mild pain, the patient may be more complaining of the way the foot looks rather than discomfort, or there may be pain in other parts of the foot due to stress caused by pathomechanics. Surgical treatment is usually done in younger people with acute trauma and orthotics and rehab in degenerative non-acute conditions. Non-weight bearing in both cases is needed for maybe 3 months. Pain on the medial side of the foot caused by biomechanical dysfunction is likely from perinavicular, talonavicular, naviculo-cuneiform or cubonavicular joints, but it may also be due to cuneo-metatarsal or intercuneiform problems. The dysfunction can be hyper or hypomobile or traumatic or microtraumatic arthritis. It is important that a full foot biomechanical exam is undertaken, not only to find the symptomatic joint, but also to search for the asymptomatic hypomobilities that may be causing or contributing to the problem. In addition, if local causes or contributors cannot be found, the entire lower quadrants need to be checked over for mechanical, neurological, or neurophysiological stresses. The plantar fascia is a thick ligament, or possibly more accurate, 3 ligaments that run from the calcaneum to the proximal phalanx of the toe. The most important part is the medial band that runs to the hallucis. It is described as working by a windlass effect, which most PTs would be hard put to define. So here is a definition. A windlass is a machine that raises or lowers a weight by use of ropes around a cylinder. This is from Rayner and Smale's blog, found at www.raynersmale.com, and I quote, "The term windlass actually is a verb used in sailing, meaning to haul or lift something using a windlass. Hicks and other researchers from this time use the word windlass to describe how the bowstring structure of the plantar aponeurosis hauls the calcaneus and first MTP closer together, and is done so when the first ray moves into extension. The outcome of these bones moving closer together in distance is a raising of the metatarsals, forming the apex of a triangle and resulting in the MLA raising," unquote. It can be understood by knowing that as the ankle dorsiflexes and slackens off the plantar fascia, the toes, particularly the hallucis, dorsiflexes and retightens it. So the tension remains roughly the same or increases, and it pulls the two ends of the foot together as a bowstring does with a bow. A 50-year-old man complaining of severe pain, as in the photograph, on weight bearing. The pain is worse after prolonged periods of non-weight bearing and gets worse with each step, eventually causing an antalgic limp to relieve the pain. The onset of the pain was on waking after backpacking in the mountains. There was no pain during the day. Not being good at packing the pack, weights of about 30 kilograms are used for an overnight hike. Or rather he, went to sleep with no pain and woke with severe pain. The attachment of the plantar fascia is exquisitely tender, and stretching of the plantar fascia reproduces the pain. The limp is immediately apparent, and the patient cannot weight bear painlessly without that limping. The question is, does this confirm to your clinical picture of plantar fasciitis? And if not, what is the problem? And just as a hint, most people would define plantar fasciitis as a pain that improves with weight bearing after the initial pain of non-weight bearing. And this really doesn't sound anything like that. This is not, in this case, the plantar fasciitis described by most texts, which gives pain after non-weight bearing, pain for the first few steps, and then the pain eases off with further walking. This is true inflammation, true plantar fasciitis, which is an enthesitis, most commonly caused by autoimmune diseases such as rheumatic arthritis and gout, psoriatic arthritis, etc., or less frequently by trauma or severe unfamiliar overuse. In the event, gout was found to be the causative factor, and the pain was eliminated by indomethacin very rapidly. So if you said plantar fasciitis, you were right, but probably for the wrong reasons and accidentally, unless you knew the information on the slide, in which case you were just right. The point of this is that fasciitis must be differentiated from fasciosis, which results from degeneration and is relatively benign and treatable, as fasciitis needs to have the cause explored and dealt with directly. The term plantar fasciopathy is used in the same manner as tendinopathy, which has the same relationship to tendinitis and tendinosis, and rupture, as fasciopathy does to fasciitis, fasciosis and rupture. So fasciopathy simply denotes that there is a pathology present in the fascia. Fasciitis is that the pathology is inflammatory but does not give the causative agent, and fasciosis is due to degeneration, while rupture may be of healthy or degenerative tissue. Clearly the treatment for each is different. Traumatic tears of the plantar fascia without risk factors are extremely rare and usually complete. They mimic stress fractures of the calcaneum but without a positive squeeze test, or they can look like spring ligament tibialis posterior tears. They can tear at the attachment or in the body, so those causing pain closer to the heel cannot be differentiated using palpation, as the blood and inflammatory products are likely to be painful even before you reach the plantar fascia, regardless of what is causing them. They occur with heavy landings, running, cutting, dancing, etc. The fact that there was no history of symptomatic pathology in the fascia, cortisone injections or disease states still does not prove there isn't underlying degeneration for more subtle reasons. At the time of the injury, there is a sudden severe pain in the midfoot or anterior heel, usually accompanied by a pop or a snap, followed by bruising and swelling. The function is severely impaired and the patient cannot walk on the foot, just limp. Low energy injuries with a history of fasciopathy symptoms or cortisone injections are much more common and are usually incomplete and less acute, with reduced bruising and swelling and function loss. Recovery without surgery is on average 12 weeks. Probably the most problematic clinical diagnosis issue is differentiating a plantar fascia rupture near the calcaneal attachment from that of the spring ligament or posterior tibial tendon. The pain is severe enough that isometric testing of the tendon will likely give a false positive, and neither the spring ligament nor the tendon can be palpated without going through the plantar fascia. On top of which, there is enough inflammatory exudate and blood in the area to make the interstitial tissues and fat tender all by themselves. If the body of the fascia is torn, and it commonly is, then a Elise Frank injury may have occurred or appear to have occurred, and excluding it in the clinic is going to be difficult. However, the body of the plantar fascia should bowstring on passively extending the hallucis, and the fascia may easily be palpated. If no bowstringing is seen, as compared with the opposite foot, then likely a tear has occurred. In less traumatic or severe cases, the bruising and swelling may be absent, but this helps rule out things like a Elise Frank injury. But everything else obtains. Surgery depends on severity, what function is being returned to, and the response to conservative treatment. A study on 4 athletes found that surgery gave better intermediate and long-term results with better control of the foot's posture and earlier return to activity. First, understand the difference between fasciosis and fasciitis, the same as you understand the difference between tendinitis and tendinosis. Everything you do to each is different. Inflammation without explanation should be considered a disease state, and degeneration should be considered treatable after you understand its cause. Second, do not ascribe to the notion of spontaneous inflammation or familiar overuse as causes. Inflammation does not just occur. It is a response to disease or trauma and should always be treated with suspicion if there is no traumatic explanation. And familiar overuse makes tissue stronger, not weaker over time, unless something changes the internal or external environment. If there is an underlying disease, then the sooner that this is found, the better, and rather than waste everybody's time treating it, to get it to a physician for definitive diagnosis. The fascia and other tissues will not degenerate as much if effective treatment is begun as early as possible, and the patient will not have to suffer your futile ministrations. Treatment of fasciitis should follow the Rice principle. I've seen a couple of these. Both had been investigated for underlying medical conditions and none were found, so were classified as inflammation of unknown cause. I treated both with shockwave therapy, very low intensity dose, just below the patient's tolerance initially, and then increasing the intensity as the time as the patient recovered. At the same time, both used progressive weight bearing on crutches, and both patients steadily recovered from the first treatment over about a 2-week period and were discharged pretty much pain-free without anybody ever finding the underlying cause. I have no idea why the shockwave would work, and perhaps it didn't. Perhaps it was the non-weight bearing and the anti-inflammatories that were taken. But recovery started fairly quickly after I initiated shockwave. I have a number of thoughts on plantar fasciosis. First, plantar fasciopathy is the most common cause of heel pain. Underneath, at the back, on the sides, wherever you want. By a long way, it's the most common. And plantar fasciosis is the most common plantar fasciopathy causing heel pain. So you're going to see a good deal of these, and you already know that. I had the good fortune to work with an excellent podiatrist in Airdrie for a couple of years. And as a consequence, I saw a lot of these patients. It's common wisdom, and I would agree with it, that remote problems throughout the lower quadrant and occasionally even further up the chain can cause or contribute to fasciosis. But the closer to the foot the issue lies, the more potent its effect. Neurological effects such as muscle intrinsic weakness from segmental facilitation, or if you prefer, central sensitization, and from reflex inhibition because of lack of nociception locally, will allow the longitudinal arches of the foot to drop and so put a chronic stress on the fascia. Calcaneal subluxations will also stress the fracture. Positioned in valgus, there will be a chronic overstretching of the fascia, and in varus an abnormal twist is applied. One treatment that is almost universally advocated is to stretch the gastrocnemius to increase dorsiflexion of the foot. But usually there is nothing wrong with the gastrocnemius, although dorsiflexion may well be limited. Usually the hypomobility results from biomechanical dysfunction at the talocrural joint, and manipulation or mobilization is a better treatment than stretching a muscle that doesn't need it. The real problem with this approach, though, is the risk to the mortise of the ankle, and you may destabilize this as you're forcing the mortise further, or the talus further and further into the mortise. It just won't give. A hypomobile ankle into dorsiflexion applies a faster and stronger force to the midfoot, which over time and with enough repetitions and force will result in the collapse of the foot and greater force applied to the fascia over a long period. Any cause of long leg on the same side as the fasciosis may result in degeneration through the chronic stress of the foot over flattening to accommodate the increased length. The major causes of long leg include extension hypomobility of the hip, loss of ankle dorsiflexion, and inability of the foot to pronate. A few minor causes in the spine and sacroiliac joint can contribute by making the whole problem worse and reducing the amount of compensation that can occur throughout the whole lower quadrant. Look for them and treat them if you think they are involved. The other issue is one of plantar fascia pain causing damage to local tissue. My experience has been that altered weight bearing results in small areas of fat pad atrophy or, less commonly, inflammation, presumably due to overloading or underloading as the gait changes to accommodate the pain. Unless this is differentiated from the fascia pain, the fasciosis will probably resolve with treatment, but the heel pain continue because of the sensitive calcaneum under the atrophy or because of the inflammation of the fat pad itself. This is very difficult to deal with, but a gel cup together with whatever orthotic you are using for the fasciosis may be helpful. I've tried low dose shockwave with iffy results, but if you know that the fat pad is the problem, once the fascial issue is clear, then you can at least change or discontinue the treatment without feeling a complete failure. There are multiple causes of fasciosis. Anything that flattens the foot over a prolonged period will increase tension on the fascia, and this chronic overstressing may cause degeneration. The causes of over-flattening are multiple, but they include intrinsic muscle weakness for whatever cause, ankle dorsiflexion hypomobility, incompetent spring ligament or tibialis posterior, valgus heel, and intertarsal subluxations. The causes of fasciosis include changes in shoe wear, particularly for running, changes to a harder habitual walking surface, etc. Fasciosis does not just happen. If there is nothing in the patient's history to give a clue, then the cause must be assumed to be asymptomatic and unrelated to changes in behaviour. So the lower limb and spine must be examined for anything that may flatten the foot or weaken the intrinsic muscles. The description in this slide is what we normally call plantar fasciitis. But if you think about it, how can the inflamed tissue improve as more stress is applied? Mechanoreception modulation of pain can only do so much, and if the mechanoreception, what's causing the mechanoreception is irritating the inflamed tissue, then the pain will increase, not decrease. This condition is one of painful degeneration. So the classic diagnostic criteria of pain after non-weight bearing followed by a pain decrease with increased weight bearing is generally found. In fasciosis, the tenderness must be looked for with deeper palpation, whereas with fasciitis, exquisite tenderness is very easy to find with much more sophisticated superficial palpation anywhere in the vicinity of the medial anterior heel. If you apply the same depth of palpation to a fasciitis that you need for a fasciosis, the patient will go through the roof and take you with him. The stress test, whereby the foot is planted with its great toe extended and having the patient bend the knee over the foot without raising the heel, and the examiner press through the foot to flatten it further, is generally not painful with fasciosis unless it's carried out immediately after a prolonged weight bearing period. In plantar fasciitis, you don't need to do this test. Simple extension, passive extension of the great toe is generally painful by itself, but the test will almost certainly be positive. I'm not a great lover of stretching the plantar fascia any more than I would agree with stretching a grade 2 MCL tear at the knee, and for the same reason. It seems to me that increasing the laxity of a ligament would be a bit counterproductive in the long term, even though it may reduce the pain at the time. I would save this particular treatment for when nothing else is working or has worked. Orthotics and taping to reduce pain when weight bearing is a good idea, as pain inhibited weakness of the intrinsics is not going to help the problem, and the patient of course needs to function. High dose, that is high dose both in intensity and time, shockwave therapy has been demonstrated to help, and my experience has been very positive in this area. High dose ultrasound may help, providing it truly is high dose, which in my opinion should be at the patient's tolerance and for at least 10 minutes. Regain ankle dorsiflexion, usually by manipulating the ankle, and also restore full pronation if lost. Take the stress off the fascia by manipulating the talocalcaneal joint, and deal with any remote etiologies that you find that may be causing neurological or neurophysiological weakness. The upcoming is a video made by my much younger brother Jim on how to manipulate an inverted and everted calcaneum. Either of these are capable of triggering or causing plantar fasciosis. Both will probably cause reflex weakness of the intrinsic muscles of the foot and consequent over flattening of the foot, so this is a good area to look at treating.
Okay, the last manipulations we're looking at on the foot and the ankle will be for the subtalar or talocalcaneal joint. And we'll be looking at inversion and eversion subluxations here, as well as at loose bodies, and these will be the first loose body manipulations we'll be looking at in the lower leg. The positioning of yourself for this is really quite important, and we'll have the patient laying on their side. Face me, please. And we'll drop the bed down a wee bit. And we're going to be using, again, an inertial manipulation, but this time we'll be using some stabilizing features as well. So if we look at the inverted calcaneus first, we need to take it into eversion. So we'll have the patient lying on their side this way and sit down. And make sure that you sit with your back to the patient. If you're sitting around this way, the thrust becomes incorrect. So have your patient back to the patient. We'll put our thumbs on the sustentaculum, which is where it's usually the anterior joint that becomes subluxed. If it does happen to be the posterior joint, and you found this by examination, then simply move your hands back. But for the most part, it will be on the anterior joint. So your thumbs need to be on the sustentaculum. You can't stabilise the talus for this. You can't get to it laterally. So any stabilisation will be done by the lateral malleolus. Essentially what we'll do is just pick the foot up like so and then flip it down. There. And at the end of the flip down, you simply thrust a little with your thumbs to force it over into that everted part. A very good description of this was given by a therapist on a course, and they said it's a bit like flipping something nasty off the end of your foot. Okay? So we'll come onto the sustentaculum, pick the foot up and flip it away from us. Okay? If the patient isn't relaxing, it is perfectly permissible to basically wobble the foot up and down until they relax. And then when you've found that they are relaxed, then apply your thrust. What you've got to be careful of, though, is that you simply don't keep on increasing the force of this flip. So at the time of the manipulation, it's a really yard long. Okay? So it's simply pick up, flip down. Okay? And you're trying to throw this into eversion. For the everted foot where you want to take it into eversion, we'll simply switch legs. I'll bring your leg over this way for me, Donna. You as the therapist stay in the same position, and this time again we'll come usually onto the anterior joint, so we'll come just in front of that lateral malleolus, like so, and essentially do the same again. We'll lift up and flip down, but this time the medial talus is accessible for stabilisation. So as we flip down, we'll simply swing our index fingers back onto the medial talus. So we'll lift up and flip down. Okay? And throw this into inversion. The loose bodies that you see here, and they do occur in the subtalar joint, give the very typical history that loose bodies give all over the body. That is of twinge pain. This pain comes on suddenly, is sharp and disappears again. And basically this is what it is a twinge of pain. The manipulation that you use for loose bodies is a little different than the ones you've used for subluxations. In these cases, they tend to be high amplitude, low velocity techniques under as much traction as you can possibly give. The idea being to flip this loose body into a non-articular part of the joint so it doesn't interfere with movement. So if we have one that is basically interfering with inversion, we'll be in the same position that we was just in for the inversion manipulation, essentially the same hand position, but this time I'll pull down through the foot to apply some traction, so I'm doing this with it, and it's a wobble, if you like, in that direction. So you're inverting it with a shake, and you're basically trying to shake this loose body across. If it was eversion that was being disrupted by this loose body, then we'll simply slip the patient back into this position and do the same as the eversion manipulation, except that we'll apply our traction again and basically wobble it over as I push through with my thumbs into eversion. Loose bodies in this joint are not uncommon, and these manipulations are something you really should practice.
Here are the answers to the opening questions. The music is Bomb by Bush from the album 16 Stone, middle 90s sometime. The photo quiz answers are left and undisplaced fibular fracture or a Weber A fracture. The middle picture is of a talar dome fracture, which is often missed after an ankle injury, only be investigated when the condition fails to respond to conservative treatment. And the right is a stress fracture of the navicular, which is not an uncommon injury. I'm getting a little bored with the foot, so I think I will change direction on the next webinar before I go stir crazy and go back to the spine, and after that come back to the metatarsalgia. So enjoy the week, be careful how you interact with people, and stay as healthy as you possibly can. Bye.